One should approach the Doppler examination in a standard, logical manner not dissimilar from a standard 2D exam. We will illustrate the normal Doppler examination by focusing first on the pulsed and continuous wave examinations and then on the color flow exam. The particular sequence of examination shown here represents our preference. Each echocardiographer should develop his or her own sequence. The emphasis of individual examinations will be dictated by the specific clinical situations. We will begin the normal pulsed wave exam with a duplex transducer in the apical position. We are interrogating the left ventricular inflow profile. We would like to emphasize at the outset that the mitral inflow profile is variable in the same individual, depending on the position of the sample volume. For the sake of consistency and reproducibility, the Doppler sample volume is positioned on the left ventricular side of the mitral leaflets, close to the tips. Here, the small 4-chamber view again shows the sample volume near the tips of the opened mitral leaflets. Each calibration marker represents 0.2 meters per second. Since mitral diastolic flow is towards the transducer, the velocity spectrum is recorded above the baseline and is characterized by 2 peaks. This is the early peak, which occurs during the rapid filling phase of diastole. It is referred to as the E velocity, and in this patient it measures 0.62 meters per second. The normal velocities are from 0.6 to 1.3 meters per second. The velocity rapidly drops towards zero and remains low through diastasis, and then increases again following atrial systole. The A velocity here is 0.4 meters per second. The normal range of the E to A ratio is 1.1 to 2.1. We are using a low wall motion filter setting in order to display all of the normal low velocity information. The sample volume is still at the tips of the open mitral leaflets. Usually in this position, the opening click of the anterior leaflet is audible. We will now move the sample volume. As the sample volume is moved toward the left atrium into the mitral funnel, the mitral closing click also becomes apparent. Note that the E velocity has become reduced to 0.45 meters per second, and the A velocity is essentially unchanged. Therefore, the E to A ratio has decreased. The sample volume has now been moved to the level of the mitral annulus. The E velocity has been further reduced to 0.4 meters per second, such that it is almost the same as the A velocity. The sample volume has been moved back to a position near the tips of the open mitral leaflets. The E point is 0.62 meters per second, and the A point is 0.4 meters per second. To re-emphasize, this is the sample volume position that should be used to characterize mitral inflow. This will be further discussed in subsequent tapes. The transducer has now been rotated and tilted anteriorly to develop the apical long axis view. The sample volume has been placed in the left ventricular outflow tract. The small 2D image is again used to document the sample volume position. Since flow through the left ventricular outflow tract is away from the transducer, the systolic velocity spectrum is recorded below the baseline. The peak here is 1.1 meters per second. Normal velocities can be as high as 1.7 meters per second. Note that the velocity spectrum has a smooth outline with a clear center. This is typical for laminar flow. The tricuspid inflow pattern can be inspected from apical, paraapical, and parasternal transducer positions. In this case, a parasternal four-chamber view has been obtained. The Doppler sample volume has been placed on the right ventricular side of the opened tricuspid leaflets. The velocity spectrum is recorded above the baseline. The E velocity is 0.5 meters per second, and the A is just over 0.2 meters per second. In the real-time segment which follows, notice that the velocity contour varies, particularly the height of the A wave. This is due to the influence of respiration. This is a parasternal short-axis view. The Doppler sample volume has been placed in the right ventricular outflow tract, adjacent to the pulmonary valve. Flow in the right ventricular outflow tract and pulmonary artery is away from the transducer. Therefore, the systolic velocity spectrum is recorded below the baseline, and this systolic peak is 0.7 meters per second. Normal velocity in adults will be up to 0.9 meters per second. This diastolic signal, which will also be apparent as an audio signal in real time, is due to pulmonary regurgitation. Trivial to mild pulmonary regurgitation is considered normal. Note the laminar spectral profile of systolic flow. The duplex transducer has been placed in the suprasternal notch, and the aortic arch is displayed in long axis. This is the right pulmonary artery in short axis. The Doppler sample volume has been placed in the ascending aorta. Flow in this location is toward the transducer, so the resultant Doppler spectrum is recorded above the baseline. The peak velocity here is 0.8 meters per second. With the duplex transducer still in the suprasternal notch, the sample volume has been positioned in the descending aorta. Flow here will be away from the transducer, and the resultant velocity spectrum therefore appears below the baseline. The systolic signal peaks at 1.3 meters per second. Since the past year, we have been systematically investigating flow velocity profiles of venous inflow into the left and right atria. These profiles provide insight into the filling characteristics of the respective ventricle and atrium and are useful parameters for assessment of diastolic function. Let us begin with an analysis of pulmonary venous flow. This small four-chamber view has been used to guide a Doppler cursor along the left ventricle and left atrium. The sample volume has been placed at the ostium of the right paraseptal pulmonary vein. The normal pulmonary venous flow is characterized by two prominent antegrade flow peaks and a smaller peak representing retrograde flow. Note that the antegrade flow has a systolic and a diastolic peak recorded above the baseline, each about 0.6 meters per second. Systolic forward flow from the pulmonary veins to the left atrium occurs as a result of left atrial relaxation and also as a result of movement of the mitral annulus toward the left ventricular apex. Diastolic flow occurs with opening of the mitral valve. Note this late diastolic reversal of 0.35 meters per second. This signal is recorded below the baseline, and it follows the P wave on the electrocardiogram. This flow reversal in the pulmonary vein is due to left atrial contraction. This line was generated through use of a nasal respirometer. With inspiration, the line moves upward, and it moves downward with expiration. To analyze flow in the right atrium, we usually interrogate the superior vena cava and/or an hepatic vein. For superior vena cava, the duplex transducer can be placed in the suprasternal notch or the right supraclavicular fossa. Here we have developed a long axis view of the superior vena cava using the suprasternal notch position. The Doppler sample volume has been placed in the cava. Since flow in the superior vena cava is away from the transducer, the Doppler velocity spectrum is depicted below the baseline. The normal venous flow is biphasic. There is a systolic wave, which peaks at 0.4 meters per second. This systolic flow toward the right atrium is due to both atrial relaxation and to descent of the tricuspid annulus toward the right ventricular apex. This represents a late systolic reversal of 0.1 meter per second. It correlates with a normal V wave in the jugular venous pulse. The diastolic flow toward the right atrium, here 0.2 meters per second, occurs with opening of the tricuspid valve. This late diastolic reversal is an A wave. It follows the P wave on the electrocardiogram, and it is generated by right atrial contraction. In the real-time examination, you will note variation in the velocity contour due to respiration, with increased flow velocities noted during inspiration. The transducer is in the subcostal position. The sample volume has been placed in an hepatic vein, which is perpendicular to the inferior vena cava. The pulse Doppler spectrum is very similar to that of the superior vena cava. We again see systolic and diastolic velocity humps, with the peak systolic velocity slightly greater than the diastolic. There are also small velocity reversals in mid-cycle and in late diastole. Having completed the pulsed wave exam, we will proceed with a continuous wave examination. Because it usually yields a crisper velocity spectrum, we prefer to use the small, non-imaging transducer for the continuous wave examination. We reserve the duplex continuous wave probe for situations where it is necessary to verify the source of a Doppler signal. For the continuous wave examination of mitral inflow, the non-imaging transducer has been placed in the apical position. The calibration marks are still at 0.2 meters per second. After mitral valve opening, the velocity increases to the E point, which is 0.66 meters per second. The velocity falls off in mid-diastole and then increases again with atrial systole. The A point here is 0.4 meters per second. From the mitral position, the non-imaging transducer is angulated anteriorly and medially to interrogate the aortic valve. Once the aortic spectrum is identified, one uses fine manipulations of the transducer until the velocity spectrum is optimized. The velocity peak here is 1.2 meters per second. Aortic opening and closing clicks are also evident. Since we are sampling blood cell velocities all along the cursor, the velocity spectrum with the continuous wave exam will have a filled-in center, even with laminar flow. Now the non-imaging probe has been angled toward the tricuspid valve. This is the continuous wave spectrum of tricuspid flow. In this cycle, the E velocity is 0.6 meters per second, and the A velocity is 0.2 meters per second. Normal tricuspid diastolic velocity may be as high as 0.7 meters per second. This is the tricuspid closing click. This systolic signal represents flow in the right ventricle towards the outflow tract. This is another patient being examined with the transducer in the apical position angulated toward the tricuspid valve. The calibration markers represent 1 meter per second. This holosystolic signal, moving away from the transducer, is tricuspid regurgitation. Trivial to mild degrees of tricuspid regurgitation can be recorded in the majority of normal individuals and represent physiologic regurgitation. The peak velocity of this signal is 2.2 meters per second. As will be discussed in a later tape, this tricuspid regurgitant velocity is utilized for determination of right ventricular systolic pressure. The non-imaging transducer has now been placed in the suprasternal notch and angulated anteriorly and to the patient's right. The calibration markers are 1 meter per second apart, and the peak systolic velocity is 1.2 meters per second. The diastolic velocity is 0.2 meters per second. This is the same subject we previously used to demonstrate the pulsed wave exam in the ascending aorta. Using the bulkier duplex transducer, you will recall that a velocity of 0.8 meters per second was obtained. Here, the smaller, non-imaging transducer has allowed us to more fully align our Doppler beam with the aortic flow. The transducer in the suprasternal notch has been angulated to the patient's left and posteriorly, and a continuous wave signal is developed from the descending aorta. The systolic peak is 1.2 meters per second, and the diastolic velocity is 0.2 meters per second. We have now completed the continuous wave examination and will proceed with an illustration of the normal color flow exam. We will begin with an apical 4-chamber transducer orientation. Left ventricle, left atrium, right atrium, and a portion of the right ventricle. The mitral valve is closed. In this early diastolic freeze frame, the mitral leaflets have opened. Note the red flow signals from left atrium, across mitral valve, and toward the left ventricular apex. This papillary muscle appears as an apparent filling defect surrounded by color. With diastasis, the mitral leaflets have moved toward the closed position. Now the valve leaflets have reopened, and there is another burst of red-encoded flow across the valve. This is due to atrial systole. With the onset of ventricular systole, the mitral leaflets have closed fully. Flow in the left ventricle is now from the apex toward the base, and it is therefore represented in shades of blue. The transducer has been rotated to obtain an apical long axis view. The mitral valve is open, and on the flow map we are seeing a red bolus of flow from the left atrium, through the valve, and to the left ventricular apex. In this early systolic frame, the mitral valve has closed. This blue represents flow from the apex to the left ventricular outflow tract. This red, near the opened aortic valve, represents color aliasing. This aliasing occurs due to the high velocity in the left ventricular outflow tract in early systole, exceeding the Nyquist limit. Now, later in systole, as the velocity has decreased below the Nyquist limit, all signals in the outflow tract are in shades of blue. The transducer is now back in the left parasternal position, and it has been tilted to develop a right ventricular inflow view. In this early diastolic frame, the flow map shows flow from the inferior vena cava into the right atrium, encoded in red because it is directed toward the transducer. This flow moves across the tricuspid valve into the right ventricle. During diastasis, the tricuspid leaflets have moved toward the closed position. Now, with atrial systole, the leaflets have opened again, and there is more flow from right atrium to right ventricle. With ventricular systole, the tricuspid leaflets have closed. This small patch of blue on the right atrial surface of the leaflets is a trivial amount of physiologic tricuspid regurgitation. As is often the case, this subject's normal tricuspid regurgitation is difficult to detect without stop frame analysis. The transducer in the left peristernal position has been rotated to a short axis view of the aorta and left atrium. This is the atrial appendage. In this systolic frame, this blue represents flow in the right ventricular outflow tract, across the pulmonary valve, and into this proximal portion of the pulmonary artery. These red signals in the left atrium are due to systolic inflow from the pulmonary veins. In this diastolic frame, we again see red signals in the left atrium from pulmonary venous inflow. This small amount of red near the tip of this closed pulmonary valve cusp represents physiologic pulmonary regurgitation. The transducer has been angulated superiorly. The aorta is partially seen in short axis. These are two pulmonary cusps in the closed position. This is the main pulmonary artery, and this is the pulmonary artery bifurcation. In this systolic frame, the pulmonary valve has opened. The pulmonary artery flow map is uniformly blue. Pulmonary venous flow can be optimized by utilizing color flow imaging to select the sample volume position. This is the apical four-chamber view. The focus is on the right paraseptal pulmonary vein as it enters the left atrium. These red signals are from the pulmonary vein. The sample volume will now be placed in this region of interest, and the characteristic biphasic flow profile of pulmonary venous inflow will again be displayed. This is the aortic arch in long axis, imaged with the transducer in the suprasternal notch. This is the right pulmonary artery in short axis. Flow in the ascending aorta is toward the transducer and is encoded predominantly in red, while flow in the descending aorta is away from the transducer and encoded predominantly in blue. The red in the descending aorta and the blue in the ascending aorta do not represent areas of flow reversal. These are regions where the flow velocity has exceeded the color Nyquist limit, and therefore color aliasing has occurred. The focus of this 2D color display is on the ascending aorta. A cursor has been directed along the ascending aorta. This display is a color M mode, which is a combination of standard M mode of structures encountered by the cursor and a color M mode display of flow along the path of the cursor. The color M mode is used to precisely analyze the timing of flow events. This cursor is not only an M mode cursor, but also a Doppler cursor. We have positioned the sample volume here in the region of the blue color alias. This horizontal line on the color M mode also indicates the position of the sample volume. Note that this line crosses the blue signals on the M mode. This is the pulsed wave velocity spectrum obtained from this sample volume position. The pulsed repetition frequency of the transducer is set at 6 kilohertz. The top of the systolic aortic signal is chopped off at 1.01 meters per second due to aliasing. This is the top of the signal, which is wrapped around on the spectral display. This pulsed wave analysis proves that the blue color is due to aliasing. If the blue had represented flow reversal, then the velocity spectrum would have originated from below the baseline. This is an identical systolic frame of the ascending aorta. However, the pulsed repetition frequency of the transducer has been increased to 8 kilohertz in order to increase the Nyquist limit. The pulse sample volume is still in the ascending aorta. Now the pulse spectrum aliases at 1.35 meters per second. Only the very tip of the signal is wrapped around. The trade-off for the increase in Nyquist limit is that the depth of view has automatically decreased. However, now the ascending aortic signals are pure red on the 2D display, and on the color M mode, there is only a very small amount of blue in early systole. We are now imaging the superior vena cava in long axis, next to a short axis section of the arch. Flow in the SVC appears in blue, since it is moving away from our transducer toward the right atrium. Next, the patient will valsalva, and you will see a decrease in caval flow. With release of the valsalva, flow will markedly increase. This concludes our discussion of the physical principles of Doppler echocardiography and the normal Doppler examination. Subsequent tapes will deal with various pathologic states, and these will illustrate how standard M-mode and 2D diagnosis are greatly enhanced by the addition of these exciting and powerful new Doppler techniques.